Mr. Angelo is a 55-year-old with a past medical history of hypertension, smoking dependence, times 40 years, presented with a chief complaint of cough and shortness of breath. The patient noted that the cough has been chronic, but now is with sputum production that is colored. Chest x-ray is clear. Patient appears euvolemic and not dehydrated. Denies fever or chills. ER calls you for admission. On exam, he has bilateral scattered wheezing. CBC is normal. What do you think about the diagnosis here? Treatment of choice. I can't tell you how many times you're gonna have this admission here. Even though we talk about it kind of in a quick manner, maybe in medical school and PA school and NP school, this is a case that's going to be on your list on a daily basis if you're an internal medicine or a family medicine resident, or again, PA or NP working in the hospital medicine world. This is COPD. So what happens is when patients smoke for so many years, they're going to have obstructive lung disease, which is we call COPD or emphysema. Okay. So this patient has been smoking for so many years. He does not have a past medical history of COPD, just history of hypertension and the history of smoking. He doesn't have an official diagnosis of COPD, but that doesn't mean it's not there. Okay. So when you see a patient who has a history of long history of smoking and they have wheezing on exam, you got to think about COPD slash or emphysema. So the only way you can really diagnose COPD or emphysema is if you do a pulmonary function testing. Do not do pulmonary function testing in the hospital, in this case acutely, because it's going to give you false results. The patient's lung is pretty beat up from the exacerbation, so it's already beat up anyway, but now you put whatever virus, infection, bacteria, allergies on top of it, and now we have COPD exacerbation. If you do pulmonary function testing right now, you're going to have skewed results.